Hello, this is Dr. Philip May. Today's topic is the evaluation and management of Prader-Willi Syndrome for primary care physicians. Before we get started, I want to acknowledge that much of the information for this presentation can be obtained from the Prader-Willi Syndrome Association website. So to learn more about Prader-Willi Syndrome, I would urge all of you to visit the PWSA website at www.pwsausa.org. I have lots of great information. Okay, let's get started. First, a little history. Interestingly, in 1887, Langdon Down, who described Down syndrome, was the first individual who provided a description of a patient that met the clinical description of Prader-Willi syndrome. This is a patient with obesity, short stature, hypogonadism, and mental retardation. And he called this polysarchia, which is just another name for obesity or corpulence. In 1956, Prader, Labert, and Willi actually reported a series of patients with a similar phenotype, and they speculated this was a hypothalamic disorder, and the syndrome became known as the Prader-Willi Syndrome. In 1976, Halkey and Smithies reported on a case of Prader-Willi syndrome due to an unbalanced chromosomal 15 translocation. And they speculated that loss of a segment of that chromosome was responsible for the syndrome. But it wasn't until 1981 that Ledbetter and others demonstrated that there was an interstitial deletion of chromosome 15 that was demonstrated in 4 of 5 patients with Prader-Willi syndrome. So deletion became a characteristic of the syndrome, but since then there have been other mechanisms which we will get into in a few minutes. The signs and symptoms of Prader-Willi syndrome include poor muscle tone at birth. They're described as floppy infants. They have distinct facial and body features. They have almond-shaped eyes, a thin upper lip, and a downturned mouth. And they have very small hands and feet. Characteristically, there's failure to thrive because they have a very weak sucking reflex and hypotonia, which is responsible for that. And sometimes they need feeding tubes just to allow them to get enough nutrition. Quite distinct from what happens subsequently when they become obese, but initially they have a very difficult time gaining weight. So they also have lack of eye coordination, strabismus, and generally they're not very responsive. So they just kind of lie there in kind of a floppy state. This is initially as infants. But during childhood into adulthood, there's an emergence of food craving and weight gain starting at the age around 2 years of age. They have bizarre food-seeking behavior. They may even go into garbage cans looking for food. They have underdeveloped sex organs. They have poor growth and physical development, intellectual disability, delayed motor development, speech problems, behavior problems, sleep disorders, scoliosis. They may have hypothyroidism. They characteristically have growth hormone deficiency, and they may also have adrenal insufficiency, all related to the failure of the hypothalamus to produce releasing hormones, hormones that stimulate the pituitary to release TSH or growth hormone or ACTH. They tend to be nearsighted and have other visual problems. They tend to have light skin and hair compared with other family members. They have a high pain tolerance and can sustain injuries because of the lack of pain sensitivity. Their temperatures may not regulate properly, and they respond adversely to extreme temperatures, hot or cold, and they may not get a fever in association with an infection. Some health complications that may develop in adulthood are obesity-related problems. They develop type 2 diabetes, sleep apnea, osteoarthritis related to excessive weight. They have hypogonadism, as I mentioned before. This is related to a deficiency of hypothalamic gonadal releasing hormones. They tend to have osteoporosis related to hypogonadism and lack of growth hormone. And they can have gastric distension and rupture of the stomach from severe binge eating. The behavior problems are characterized by stubbornness, and they may have temper tantrums. To understand Prader-Willi syndrome, it's important to understand the concept of imprinting. And a healthy person receives 2 copies of chromosome 15, one from the mother and the other from the father. However, in the region of chromosome 15 that is critical for Prader-Willi syndrome and also for Angelman syndrome, the maternal and the paternal contributions express certain genes differently. And this is due to a gender-specific imprinting. And the biochemical mechanism of imprinting is excessive DNA methylation. So hypermethylation silences the gene. So in the normal individual, the paternal, the father's Prader-Willi DNA site is normally methylated or turned on, while the mother's or maternal DNA site is imprinted, that is hypermethylated or turned off or silenced in the developing hypothalamus and other parts of the brain. Therefore, if the paternal contribution is lost, inactive, or mutated, the result is Prader-Willi syndrome. So even if there is mother's Prader-Willi site DNA present, it will not work because the maternal site has been silenced by imprinting. Okay, let's talk about the SNRPN gene. This is a Prader-Willi gene, but it may be the main Prader-Willi gene, just like the UBE3A gene is the Angelman gene. The SNRPN gene may be the most important gene leading to most of the symptoms of Prader-Willi syndrome. Stands for small nuclear ribonucleoprotein associated protein N gene. So of course the genes make proteins. So the small nuclear ribonucleoprotein associated protein N gene makes the analogous protein. So this protein participates in the production and function of messenger RNA in the hypothalamus and other parts of the brain. And when the protein is missing, the hypothalamus does not function normally. And this leads to loss of ability to control appetite and a variety of endocrine deficiencies, especially growth hormone and the gonadotropins. The prevalence of Prader-Willi syndrome in the United States is 1 to 10,000 to 1 to 15,000, similar to Angelman syndrome. It's not as common as Down syndrome, but you will see these cases. They're not excessively rare, and in any population of people with developmental disabilities, you're going to see people with Prader-Willi syndrome. Let's take a couple of minutes and go over chromosome 15. The chromosome 15, like all chromosomes, is divided into a P arm and a Q arm, as shown on the left-hand side. The P is the short segment and Q is the long segment or arm. And the Q arm is subdivided into segments 1 and 2, and they're subdivided into segments 1, 2, 3, 4, and 5, and segment 1 and segment 2 is subdivided into 6 different subsegments. And what we're talking about is subsegments 1, 2, and 3 of segment 1 of the Q arm of chromosome 15. So the nomenclature is 15q11 to 15q13, shown on the blue up and down arrow, is the segment we're talking about. And if you go to the right of the chromosome, you can see all the genes that are listed in that area. And if you want to learn about these genes, you simply enter them into Google, and you'll be amazed at what you can find out about what those genes do. So just take a look at the very top there. The HERK2 has to do with eye pigment. If you look at moving down, you come to the SNRPN gene, which is the Prader-Willi gene. If you go down further and looking at those red areas, you see the UBE3A, which is the Angelman gene, and the green P is skin pigment. And there are a lot of them there. I have no idea what they do. I've never looked them up myself, but if you're really interested in this type of thing, you may want to Google some of those and find out what they do, because knowing what the function of those genes are will explain the symptoms of Prader-Willi syndrome. And some are paternally expressed, as shown in the blue, and that's what we're focusing on today, is the paternally expressed genes, or the Prader-Willi genes. And the most important one, I believe, is probably going to be the SNRPN gene. Also, you notice the IC, that's the imprinting center. The imprinting center is the gene that methylates the imprintable genes and turns on and off the genes depending upon whether they come from the mother or father. And in the case of Prader-Willi syndrome, the paternally expressed gene is the SNRPN gene in the blue. So that's what we're focusing on today. There's also a lecture on Angelman syndrome in this series. I advise you to look at that too, because it's very much related. And this is a slide courtesy of the Angelman Syndrome Foundation, another great website that I would suggest you visit. But this is the same information, not as detailed as the previous slide, showing the different genes. And in one situation, you get the Prader-Willi syndrome, and the other is Angelman syndrome. Now, there are different mechanisms for Prader-Willi syndrome, as there are for Angelman syndrome, and 70% of cases of Prader-Willi syndrome are caused by a deletion of the father's or paternal chromosome. 25% are caused by a uniparental disomy. In other words, the patient inherits 2 maternal chromosome 15s, and 5% are caused by an imprinting center defect. In other words, there's a gene which turns on the SNRPN gene, and that may be defective. It's never turned on, so they're deficient in SNRPN because the imprinting center doesn't work. So the challenge to the geneticist is to determine what is the cause of Angelman syndrome, because you can get the same clinical syndrome from these three different mechanisms. Now here is an example of what's done called a methylation test of southern blot. It's a type of chromatography or electrophoresis where the chromosome 15 segment, the Q11 and Q13 segment, is electrophoresed and separated and stained with a specific DNA probe. And you can see in the normal situation, the N at the top there is a normal. You see two bands, one coming from the mother and one coming from the father. That's the normal result of this methylation testing. But in a person with the Prader-Willi syndrome, only the maternal segment is present. The paternal segment is missing. In Angelman syndrome, it's just the opposite. You see the paternal chromosome 15 segment, but no maternal chromosome 15 segment. And as I mentioned before, just focusing on the Prader-Willi syndrome, there are three mechanisms that would give that pattern. First, there could be a deletion in 70%. It could be uniparental disomy, maternal uniparental disomy could cause that, or there could be an imprinting center defect. Now, the FISH test is what's used to determine whether it's a deletion, and you can see in this slide the results of a FISH test. The two dots on the top are markers for chromosome 15, so you know you're only dealing with chromosome 15 here. And you can see at the bottom of the chromosomes there's one intact and one deletion. Now this is Prader-Willi syndrome, and you have a deletion present in 15. You know that's the cause of the Prader-Willi syndrome. If it were Angelman syndrome, you'd be looking at the mother's chromosome 15 with the deletion. Okay, this is a scheme for the genetic testing for Prader-Willi syndrome. Looking over on the left-hand side, if Prader-Willi syndrome is suspected clinically, you can obtain a blood test for DNA methylation, kind of a southern blot type of analysis. And if the methylation test is abnormal, just following the arrows here, you can see there are three mechanisms that are possible. There can be a chromosome deletion, uniparental disoming, or imprinting defect. So you do a FISH test, and if that's positive, then you've got 70% with that kind of finding, then you've made the diagnosis. However, if the FISH test is normal, you still have two other possibilities. You can have a maternal uniparental disomy, or you can have an imprinting center defect. That's going to be 25%. So you can do a DNA marker analysis to see if this is the maternal chromosomes, and there's certain genes that only the mothers have, and there are others that would only be present in the father. You can determine whether, if there's an absence of the paternal chromosomal material, then you've got the diagnosis of maternal uniparental disomy. However, if that is normal and both maternal and maternal chromosomes are present, then there's a presumed imprinting center defect, and you can do further DNA analysis to confirm that. So it's recommended, and there are different approaches to this, but this is a common approach to order a methylation test first. That'll pick up virtually 100% of the cases of Prader-Willi syndrome. And so if you have a case, say an adult with severe hypotonia, and you're considering some kind of neurological problem, it makes sense to go ahead and do a methylation test. This is somebody that could have Prader-Willi syndrome, to rule that out. You don't know whether it's uniparental disomy, or whether it's a deletion, or whether it's an imprinting center defect, but it's going to be one of those three in virtually all the cases. I'm sure there's no such thing as 100% of everything, but they're probably going to turn out to be a few rare cases of other causes, but practically speaking, that will confirm the diagnosis of Prader-Willi syndrome. So then you follow up with the FISH test and other types of DNA marker analysis to actually determine exactly the cause. And it's important to do that, and I'll get into that in just a minute. Okay, let's talk a little bit about the pathophysiology of Prader-Willi syndrome. It appears to be a dysregulation of the feeding, satiety centers, and pituitary hormone-releasing factor centers in the hypothalamus. When you need food, the vagus nerve sends a signal to the stomach. And it turns out that one of the results of the vagal stimulation is the release of ghrelin. And ghrelin stands for GH, growth hormone, REL, release, induction, or something like that. It has to do with growth hormone release. So ghrelin is released, and that stimulates the appetite. On the other hand, when adipose tissue will reduce leptin, and leptin suppresses the appetite. So it's felt that there's some kind of hypothalamic insensitivity to leptin, or a loss of control of the vagus nerve, leading to stimulation of the stomach to release ghrelin. And this somehow leads to the syndrome. So honestly, I don't know a lot about this biochemistry, but it's kind of interesting, and if you're interested in this type of problem, I would suggest you read more about ghrelin and leptin. Next slide, I'm going to show you a little bit about leptin. In Prader-Willi syndrome, on the top right there, it shows a slide showing that leptin levels and leptin messenger RNA levels are actually elevated in Prader-Willi syndrome, but also in obesity in general, they're elevated. So it's not clear that this is specific for Prader-Willi syndrome, but if you have increased leptin, your appetite should be severely suppressed. And so it's kind of interesting that these people have all this leptin, but it's not working. So there must be some kind of insensitivity to leptin in the hypothalamus. At least that's the theory. Okay, some other additional management treatment considerations. Because of the behavior problems, they may end up on a lot of polypharmacy, psychotropic polypharmacy, and you have to worry about long-term drug toxicity from this. They tend not to get a lot of weight-bearing physical exercise, and this can lead to osteoporosis. They can be vitamin D deficient from obesity, as well as perhaps other causes, maybe drug toxicities. There does appear to be an increased risk for fractures. There are very few studies on this, but they tend to have low bone mineral density. Because they have muscle dysfunction, they're at risk of injury from falls. So in conclusion, Prader-Willi syndrome is not rare and is the most common genetic cause of obesity. In making the diagnosis, early childhood history is very important. You get the history of the floppy infant. People with Prader-Willi syndrome are living longer now. In fact, you see at the bottom of this slide, you see a reference to aging Prader-Willi syndrome. Very little is known about the optimal management of the aging adult with Prader-Willi syndrome. It's still pretty much in the realm of the pediatrician, but there is a need for primary care physicians and endocrinologists that take care of adults to learn more about this syndrome. Uniparental disomy and imprinting center defects are associated with a milder clinical course and better longevity. And this is true for Angelman syndrome as well. The imprinting center defects can be transmitted genetically. So a parent that has this imprinting center defect, this can be a genetic and inherited cause of Prader-Willi syndrome. But the others, especially the deletions, tend to be just spontaneous mutations and don't represent an inheritable type of condition. But it's important to know about the exact cause of Prader-Willi syndrome for genetic counseling and prognostic reasons. Okay, that concludes the talk. Thank you very much for listening. If you want to ask me a question, send me an email to ifcd.pmay@gmail.com. You can visit our website at www.chronicdisabilities.org. That's the International Foundation for Chronic Disabilities. We have some other lectures in this series on our YouTube channel at www.youtube.com/user/PhilipMay123. Thanks again. Bye-bye.